Welcome and thank you for joining today's webinar on jail reentry for people with substance use disorders, part 2, creating a continuum of care with the National Association of Counties and the Institute for Intergovernmental Research, funded by the Bureau of Justice Assistance. This webinar is part of a 3-part series that will be offered during the month of March. Part 3 of this webinar will be offered on March 30th at 2 p.m. Eastern. Click the link in the chat box to register. You should have access to that in your chat box now. My name is Elin Lee, and I'm the Program Manager for Justice at the National Association of Counties. Before we get started, just a reminder that this session is being recorded and will be available on the NACo website following the webinar. Please feel free to use the chat box to post any questions you may have throughout the webinar, and we can address them during the Q&A portion at the end of the session. During today's webinar, you will hear from experts and leaders highlighting strategies counties can use to partner with community-based providers to ensure seamless connections to care when people are released from jail. Next, I will pass it over to Kathy Rowans from IIR to introduce herself and for opening remarks. Kathy.
Hi, everybody. My name is Kathy Rowings, as Lean said. I'm a senior research associate at the Institute for Intergovernmental Research. We provide training and technical assistance to sites across the country under the Bureau of Justice Assistance's Comprehensive Opioid Stimulant and Substance Abuse Program, or COSSAP. And I just wanted to give you all sort of a quick overview of COSSAP, since you'll be hearing from sites that are funded under this grant program. And so sort of the big overview of COSSAP is that it provides financial and technical assistance to states, localities, and tribal governments to plan, develop, and implement comprehensive efforts to support those who are impacted by substance use disorder. So what that sort of means in real life is, since 2017, the Bureau of Justice Assistance through COSSAP has supported innovative work that aims to reduce overdose deaths, promote public safety, and support access to treatment and recovery services in the criminal justice system in over 500 site-based projects and demonstration projects across the country. And today you'll be hearing from 2 sites that are funded through COSSAP. First, you're going to hear from Northern Kentucky University, which is a participant in the Rural Responses to the Opioid Epidemic Initiative, or RROE, and RROE supports 21 rural sites across the country as they've worked to identify gaps in prevention, in treatment, and or in recovery services for individuals who have SUD and who encounter the criminal justice system. And then those 21 sites have working to implement or enhance activities to close those gaps and really just strengthen efforts, again, to address the substance use crisis in their communities. And then you'll also be hearing from Albany County, which is a part of the Evidence-Based Treatment in Custody Jail-Based Mentor Site Initiative. This COSSAP initiative offers jails across the country who are interested in either providing or enhancing medication-assisted treatment services. They can take the opportunity to observe and learn from innovative programs that have demonstrated success in actually meeting the treatment needs of individuals with substance disorders. So 5 sites were selected to serve as mentor sites in this program, and Albany is one of them. And so on this slide, you can see just a quick overview of some of the resources that are available through COSSAP, including training and technical assistance. And I definitely want to highlight that you do not need to be a COSSAP grantee to request support. We have a lot of partners and a lot of sites, as I mentioned, there's 500 plus that we can connect you with to support your work, answer questions, help you sort of troubleshoot and brainstorm, all of that good stuff. So please don't hesitate to reach out. And you can also learn more about upcoming funding opportunities and join our listserv to make sure you're always up to date on all the good info. Elin, next slide, please. And then just quickly, here's the website where all of this great information is housed. It's www.cossapresources.org, and I can drop that into the chat as well. And again, this is where you can go to request that training and technical assistance, where lots and lots of resources are housed. We've got publications, webinar recordings, site profiles, information about all sorts of funding opportunities, just a lot of good stuff. And then also where you can sort of learn more about COSSAP as a whole if you're interested. So encourage you to check it out, and just want to say, don't hesitate to reach out with any questions at all. That's it from me. Just wanted to, like I said, give a quick overview of these projects before we let the folks actually doing the work dive in and share all the cool stuff they're doing. So with that, I will turn it back over to Elin. Thanks.
Thank you, Kathy. Well, now I'd like to introduce the speakers for today. I will first pass it over to Valerie Hardcastle. Valerie Hardcastle, she is from she's the St. Elizabeth Healthcare Executive Director of Institute of Health and Innovation and Vice President for Health Innovation at Northern Kentucky University. I'll pass it over to Dr. Hardcastle to give a brief introduction of herself.
Oh, thank you very much. I was not anticipating introducing myself. I think you did it just fine. I've been at Northern Kentucky University for 3.5 years now, so I'm still relatively new, but I've been in this region for 15. Before that, I served in a variety of different administrative roles at the University of Cincinnati. Before that, I was at Virginia Tech, and then before that, it's kind of ancient history, so it doesn't even matter.
Thank you, Dr. Hardcastle. I'll now pass it over to Ed Fox, who's the Director of Project Safe Point in Albany County, New York.
Good afternoon. I wasn't expecting to introduce myself either, but I'm Ed Fox. I'm the Program Director at Project Safe Point. We're a harm reduction program. All of my work is really based on the harm reduction model. I've worked in harm reduction for a very long time, providing services, syringe exchange, safer injection counseling, overdose prevention, and all of the work, especially in these counties surrounding the capital district where we're based. And I oversee the staff, the community component of the program, the MOUD program at Albany County Jail.
Thank you, Mr. Fox. We'll now kick off into presentations. I'd now like to kick it off to Dr. Hardcastle for her presentation.
Thank you. So today we'll be talking about what I have just called recovery care teams and overcoming unintentional barriers. Next slide, please. So first, I would like to kind of paint the picture of the challenges that we have both in the Commonwealth of Kentucky as well as the region I'll be talking about. So Kentucky has the second highest rate in the nation for children with at least one parent incarcerated. Here in Kentucky, we always say, you know, thank goodness for Arkansas, which is probably a terrible thing to say, but we do nonetheless. It's got the second highest rate for female incarceration. Our jail population increased by 22% during COVID. 37% of those serving time for a drug conviction are reincarcerated within 3 years. And our drug arrest rate for the Commonwealth is just shy of 2,000 people per 100,000 arrests, which works out to be about 28% of all arrests are drug related. Now, the counties that are in our geographic region of interest are Carroll and Owen County. And they are in what's known as the Golden Triangle. They're kind of equidistant between Cincinnati, Lexington, and Louisville for people who are familiar with what Kentucky looks like. They're especially challenged, in my opinion, because they're rural counties, but they fall outside the two regions in Kentucky that get a lot of attention paid. And I don't want to disparage the regions that get attention paid because they need it. And that is the Appalachian region, coal country, and the second is the Delta region, what kind of extends down into Tennessee. So this is kind of a neglected region in Kentucky. Now in Kentucky, over 50% of our arrests are drug related. So that contrasts with the Commonwealth itself. And over 50% of those incarcerated are convicted on drug charges. Approximately 85% in these counties who are detained or just as involved misuse substances. So a lot of times the actual reason they are in detention has something to do with misusing substances, but the charge may not reflect that because it's probably burglary or something like that, which they were doing to be able to support their substance of choice. The drug related arrest rate is 5,207 per 100,000. So you can see it's more than 2 times higher than what you find in the Commonwealth. The Carroll County Detention Center, which serves both Carroll and Owen counties, has space for 120 people, but right now it's got 166 detainees in it, so it's quite crowded. And what's important there is there is no behavioral health care, nor is there any specialty medical care available. So they do have one nurse who comes by 3 times a week to provide whatever basic medical assistance one needs, but she cannot prescribe any medication, nor can she offer any specialty services. So if you come there with a substance use disorder, you're pretty much out of luck. You just have to kind of grit your teeth until your time is done. Next slide, please. Now, once you, if you're outside the detention center, healthcare remains a challenge in both Carroll and Owen counties. It's a designated health professional shortage area in both primary care and mental health care. The ratio of primary care providers to residents to primary care providers is 2,660 to 1, which is compared to 1,520 to 1 for Kentucky and 1,321 for the United States. So very severe shortage of PCPs. The ratio of mental health providers to residents to mental health providers is 2,690 to 1 in the counties, compared to 490 to 1 for Kentucky and 470 for the United States. So you can see when you're talking about mental health, behavioral health care, there is a severe, severe shortage. In fact, there is no full-time behavioral health care provider across the 2 counties, which I note covers almost 500 square miles. There is no one waived there to provide buprenorphine, and most care occurs out of the county, 40 to 90 minutes away. And as you can, for those of you who work in rural areas, you know that that's a problem because there's also no public transportation there. That we do have Medicaid transport, but outside of that, no bus system, no Uber, no Lyft. If you don't have a car, in a lot of cases, you are really challenged in being able to travel for any sort of healthcare. Next slide, please. So we implemented a model of care coordination when we first received grants for this region. The idea here, and you can see Shanna Osborne, who's our care coordinator in Owen County, is to provide essentially compassionate care coordination. She talks about herself as the mom to all of her clients, and she is one of the most dedicated people I know. But her goal is, her title, her job duties, I should say, are to connect people in the county to the resources they need, whether that is food, shelter, specialty care, basic care, mammography, dentistry, substance use disorder treatment, follow-up, groups, whatever it is. She says, she's the human yellow pages for substance abuse treatment and recovery. But she also, in doing that, wants to work with the clients to teach them how to problem solve, to help to identify and reduce barriers to achieving recovery, to encourage self-efficacy, to help manage resistance, and to help promote non-dualistic thinking. And we want to do that to obviously to reduce relapse rates, but also to increase healthcare utilization. Because one of the things that happens when you don't have a healthcare infrastructure in a community is people stop seeing that as an option. And so even when you need some sort of healthcare, people often won't seek it. So there's just not a good culture of health there. And part of our goal in creating a care coordination is to help people understand that there are actually resources there. It's just a little complicated to access, but we will help them do that. Next slide, please. So we put together a team, and these are the primary people in our recovery care teams. North Key Community Care is the regional community mental health provider. The Carroll County Detention Center, The Northern Kentucky Office of Drug Control Policy, which does a lot of data collection and tracking of first responder activities. The Public Defender Office, the Institute for Health Innovation, where I work. Kentucky Department of Corrections has been instrumental in working with us on the recovery care team. And then Owen County itself, as well as, well, I mentioned the Carroll County Detention Center. So we are all coming together to form a group to help people re-enter the community. Next slide, please. And so the logistics of creating this group, it's got the official Kentucky Department of Corrections stamp of approval on it. They have approved our data sharing and confidentiality agreements. Each of the members signs these, and then the detainees must also give their signed consent, allowing us to talk about them and talk about private medical information. And the point here is that we have weekly meetings to try to problem solve on barriers, and I'll talk about one in just a moment, give you an example of what I'm talking about. All of our data and outcomes are kept on a HIPAA compliant platform that is run by the Northern Kentucky Office of Drug Control Policy. And that will also allow us to kind of run cross checks because different people can input data on this platform. And that's actually really important, because one of the challenges when you've got healthcare spread out across probably 20 different counties is the providers don't know what other providers are doing, because these are different healthcare systems and they don't always talk to each other. And so when you have a patient with complex medical challenges, perhaps a co-occurring disorder along with substance use disorder, it can be really tricky trying to keep all this together. Now, the point of these weekly meetings is not just to talk about sort of the care and feeding of the detainee, but it's to help solve problems that unintentionally arise given our sort of complex, not really a system, but more a kludge that the detainees have to navigate. So one example is if you're on parole for a substance use disorder violation of whatever type, not surprisingly, you have to do random drug tests. That seems fine. Unfortunately, the nearest place to get a DOC sanctioned drug test is in Covington, Kentucky, which is an 1.5-hour drive from Owenton, which is the primary, I wouldn't call it a city center, the town in Owen County. And if you live on the outskirts or even further away, it can be up to a 2-hour drive. Now, first, if you don't even have transport, you don't have a car, that's a problem. The second problem is if you have a job and if you're a detainee out on probation, probably the job that you have is an hourly wage job. That's at something like a cafe, a McDonald's, a hardware store. Maybe you're working at a nearby factory. These are not jobs that you can just say, hey boss, I'm going to take off because my card came up. I've got to take off for 5 hours this afternoon so I can go get drug tested. Now, nobody wants the detainees to lose their job. Everybody thinks they should submit to random drug testing, but this is a problem that we have to solve. Like, how can we work around this? Can we do mobile drug testing, for example? Next slide, please. In addition to that, we try to provide a modicum of continuity of care from the detention center out to reentry, because we know that when people are released from detention or prison, that is the most vulnerable time for them. And it makes sense, because even if they've been receiving care in detention, once they're released, they have a whole bunch of pressing issues on their plate immediately. I need a place to live. I need to get food. I need to have a job. Maybe I need to figure out what happened to my kids. And because of that, caring for yourself and doing something about your treatment plan often takes a back seat. So we have an instructor that is grant funded that works in the detention center who provides moral recognition therapy, which is a cognitive behavioral therapy that emphasizes personal responsibility. It is shown to work quite well with the detainee population. We also offer GED courses, and the same guy also sponsors our NA and AA groups there. He's in long-term recovery himself. He's a fabulous guy because he has walked that walk and is ready to assist. North Key also, well, I would say they had a therapist there who left us, and unfortunately that position is not there right now. But we also have a North Key therapist who can work with patients and provide a modicum of treatment support around substance use disorder. And starting next month, we also are going to have peer support specialists in there who can help, who can assist with the groups, the MRT, and the therapist. The point here is that when they leave detention, all of those people will still be in their corner. And so the North Key therapist the same therapist will continue with them, meeting them in the detention center as well as outside when they're on probation, also meets in parole. The peer support specialist will walk them through leaving detention and helping them to get settled. And these peer support specialists have been through this process themselves. And as I said, the person who runs our NAAA groups, he runs them in the detention center as well as outside the detention center. And so they can have a continuity in care, hopefully providing enough structure that we won't lose them as they're trying to figure out the rest of their life. Next slide, please. And so we've just started this program. So the data analysis and data collection is just beginning. Perhaps you can invite me back soon and I can tell you whether this experiment is worked out well in our community. We have started offering MRT in the community. Word has gotten out. And so now it's actually being offered in the high schools in lieu of suspension or expulsion for students. There've also been community members and churches who've asked if we can offer MRT in their programs, and we're happy to do it. Community support groups have increased, so our numbers have increased in our groups on the outside. So we're starting to develop some sort of sense of a recovery community. The demand for our care coordination services has gone off the charts. We'll probably try to see if we can figure out how to hire some more care coordinators, more peer support specialists. Right now, we've got 4 working for us, and I think we're going to try to have 2 more hired in the next month or so. And we're actually trying to start a recovery house and a recovery community in Gratz, Kentucky, which is kind of equidistantly located between Owenton and Carrollton, which are the 2 primary residential centers in the 2 counties. Next slide, please. Okay, so that's it for me. And I understand questions will be taken at the end. So I will hand it back to our MC.
Thank you, Dr. Hardcastle. Next up, we have Mr. Fox. I will now pass it over to you.
Okay, great. Thank you. Next slide, please. Okay, so I'm going to talk a little bit about the medication for opiate use disorder program at Albany County Jail. But first, I want to bring a little context to this conversation. And, we're an outside agency, and I want to sort of, give an idea, a snapshot of like what it takes to be able to support a program like this. The jail, its population as of early yesterday was 350 individuals, and it's a fairly large county jail. So that just gives you an idea of, the population we're talking about. But back to our Project SafePoint and the services we provide. So we're a harm reduction program. Our, goals are, to connect and provide services for persons who use drugs. Again, disease prevention is a very large part of all that. So we started out as 8 services, and we continue to provide disease prevention services, HIV, hepatitis C, and obviously overdose prevention, which is a huge part of this conversation and a huge part of our work as well. We really try to connect with people in systems around overdose prevention, and we're going to talk a little more about that as we go through the slides here. Our services are really provided on the continuum of care. So we really look at, people who are, at the very sort of beginning stages of the continuum all the way through to maintenance on the continuum, as I said, all the way through substance use services. Next slide, please. Our goals are here. Again, it's reducing the numbers of overdose fatalities and disease, connected to substance use disorder, reaching, vulnerable and disengaged populations, which is a huge part of what we try to do, because our people are notoriously difficult to engage and connect with. So, that is a huge part of what we do. And again, it's always linking people who use drugs to, services that are going to sort of reduce their risks for overdose and overdose fatality and other disease. Next slide, please. And these are the services that support the program. I think it's important to be able to show those. So we have a drug user health hub, and that sort of is an umbrella for services. Our syringe exchange program is, our bottom line program. We provide services in 12 counties surrounding the capital region. So it's quite a large geographical area. And you do have a range of, urban, suburban, and rural, and all of, like I said, all three. And these services are provided throughout all of these areas. We have an opiate overdose prevention program. We do outreach, like street outreach, and varying kinds of outreach, whatever it takes to connect with people. We are a provider as well, so we have very low barrier buprenorphine clinic. So we have a provider here who actually prescribes and allows easy access to medication. And again, the disease prevention piece, we have like a patient navigation program where we walk people through treatment for hepatitis C, because the prevalence of hep C amongst our population, and the real sort of goal is to sort of really take those numbers way down. And we do have a peer navigation program, so people with lived experience that are really connected to people who may need that little extra piece, of support. And we work with a variety of entities, like I said, the hospital systems, the treatment systems, and law enforcement as well. And we have a LEAD program, a law enforcement assisted diversion program, which we work with the local police department, the Albany Police Department, to sort of, instead of arresting everybody, we can offer like care coordination or case management services, and work with people to hopefully provide different outcomes. Next slide, please. Okay, so the jail itself. So again, it's how do we get involved with this? What is the history here? I think it's worth to sort of take a look at that. So I've been going personally, and my staff have been going to Albany County Jail for a good number of years, doing overdose prevention training for the general population at that facility. So we would go every other Friday and do overdose prevention for a group, and we would leave Narcan kits where people could pick them up in their property when they were leaving, which was really fantastic, because I think most people know the risk for overdose is astronomical for people post-incarceration. So having that Narcan kit in someone's property when they walked out the door is very, very important. And we've been doing that for many years, but it also allowed us to have conversations with people, just to connect and talk about, risk and, prevention and all of the services that we provide. And, we found over the years that people would connect with us. We would have like contact information in the property as well, where someone can come back, maybe need another Narcan kit, maybe they need, treatment, maybe they need, an array of services. So that was a way for us to connect with people incarcerated at Albany County Jail. Again, can you go back, please? The goals again was all of the sort of harm reduction. Just so in the beginning stages of the program, we were very well positioned. We used to do a lot of work with the Albany County Sheriff to sort of talk about our services, because sometimes buy-in is hard to get, and by sort of the soft approach, we were able to sort of get buy-in and be there when sort of change started to happen within the jail. Next slide, please. All right, so the background of the program at Albany County. So it happened very suddenly. Again, like I said, we were very well situated to sort of be there when this started. So in January 2019, with a collaboration of a lot of different entities, we had New York State Department of Health, we had the Harm Reduction Coalition, we had local stakeholders, treatment providers in the community. Everyone came together to sort of design this program, really, and we decided we were going to sort of do a logic model. So the logic model was set up in a way that we would implement the program in 3 different phases. So phase 1 of the program was implemented in a way that anyone coming into the jail who was already on medication would just be continued on medication for their time there. And that was the first phase of the program, which was a very short phase. That happened, that started in January. By March, we had sort of moved on to phase 2, which was much more comprehensive. And anyone with opiate use disorder who had an out date was eligible to be a participant in the program. So that really increased the numbers. So by August of 2019, we were up to like 100 people almost at the jail. And the interesting piece about that, this is sort of the context piece I was talking about earlier, of those 100 people that were on the program and the early stages, I was able to say 55 of those people were people we hadn't worked with already, whether it was through our syringe exchange program, which was through our lead program, which was through our care, we have care coordination as well, all of these programs. So, it really speaks to the people, who use drugs and, connecting with them in the systems, in different systems. So, that was a very high number, and that really always stands out for me. November 2019, phase 3 began. So that was like the final stage. It was like open to all individuals at Albany County that were suffering from opiate use disorder. And that really opened the doors. So we, at that point, started to really expand services. The initial stages of the program, we had a harm reduction a reentry specialist engage with everybody. Now we took on another specialist to sort of connect with people. But we were using all of the other programs. We were using the peer program. We were using, the patient navigation program. We were using our outreach specialists here, our, street level outreach specialists as well to support the program and, support people, when they post incarceration. Because one of the very important points here for us to always make is we're a community-based organization. So most of our work is happening in the community. Also in 2019, and it just says it there, I do feel I should mention this, our grant funding, we're a grant-funded agency, and our funding, original funding was changed. So we were funded through the overdose response strategy, or NACo, and they were our funders for a couple of years up until sort of the summer of 2021. Next slide, please. Okay, so how does it all work? What does it look like on the ground? So really, we have protocol and strategy in place. We've learned as we've gone along, of course, as well, but we have a very solid sort of way of working. And the initial stages, we were emailed referrals from the jail as people were identified and were taken onto the program. And our goal was to visit everybody within 24 hours. More about that in a little while. But that was this sort of our strategy within 24 hours. However, the weekends, because we weren't able to visit the jail, we weren't going to the jail on the weekends. But our main goal was as best we could see somebody within 24 hours. We put together, obviously, a needs assessment form, which I'm very happy to share with anybody. We have we designed a Creating Reach Beyond the Jail Walls, an implementation guide for harm reduction wraparound services. I know that's a big mouthful, but I'm very happy to share that with anybody who's interested, and I'll put it in the chat as I wrap up here. But the assessment is part of that as well. It just shows you the kind of information we look for. We look for everyone's harm reduction strategies, because a lot of the work is safety planning with individuals, and there's many different levels of care that are being provided. So it's trying to identify them as best we can, and work towards, whatever needs are relevant when someone post-incarceration. And we always do an overdose prevention training as part of our initial encounter with somebody. So everybody gets a Narcan kit, and we talk about, overdose prevention. Just to sort of a reminder, a lot of people have, have sort of the knowledge, but again, I think it's just as a reminder for people, reminding them of the risk post-incarceration. So that's very much, part of the sort of initial meeting with an individual, and that's in everyone's property. And regardless if somebody is going on to prison, the Narcan kit's going to follow them, whether that's to a family member or to a, next to, whoever that might be, whoever they decide should have that. If they're not able to get that themselves, we sort of make sure that follows them. And again, obviously planning, to identify any other barriers, because a lot of the barriers are, housing, which is a huge challenge here, as it is throughout the country. Doing what we can to sort of link and work around all of those barriers, because these are all barriers and these are all very relevant to overdose as well. And then again, more visits as needed. So we will go and see somebody as many times as we need to see them. I have somebody who's the longest person in the jail. I just found this out today. He's being released next week. He's been there for a very long time. And we've seen him so many times, but again, we will go back again next week. He's due out on Thursday. We'll go back on Wednesday just to tie up the pieces. He's going to come to our clinic here, and we're going to just to make sure everything falls into place for his release. We will pick him up if that's what the plan is. It can look anyway, so we're very flexible and willing to sort of work with the individual as needed. Next slide, please. Okay, so the community, again, what does that look like? So connecting in the community is, again, as I mentioned a few minutes ago, we are a community-based organization. So this is where the real work happens for us. The in-reach is very much the engagement. It's, being able to see somebody and being able to have a conversation with them. So, how does the outreach work? One of the amazing things about this program has been that individuals leaving the jail are being given a 30-day script, for the buprenorphine, which has been huge because that allows us to do the work. So, when, as a lot of you on this call will very much be aware of, that risk for overdose post-incarceration is through the roof. This is really a high-risk time because of tolerance and because of, other factors. So, being able to sort of maintain somebody, immediately after they get released is very, very important. And, when I say we're going to meet you at the jail gates, I mean that because, again, we recognize the importance of, really getting people connected as quickly as possible post-incarceration. I'm working with all of the other services because they're all there. Like insurance, of course, is a big issue because, especially someone who's been incarcerated for a minute, their insurance is on hold. So making sure that gets switched on as quickly as possible. And again, all of the other pieces I mentioned sheltering earlier, it continues to be a major challenge, as it is, like I said, everywhere. And for a lot of people, the work is safety planning. Yeah, it's making sure someone is connected to our syringe exchange program, connected to, making sure that they can have access to fentanyl test strips, all of those services, and being able to talk about them and making sure people are comfortable accessing those services, which sometimes they're not, but, that is very, very important. Peer support, I can't say how important that is. People who have actually been there, who've walked out of that jail themselves and been able to sort of walk the same walk as somebody walking back into the community. And that's a very important component of services being delivered from our agency. Next slide, please. And again, these are the goals for the program. It's just really to connect with everybody, which is really important. And we have been able to do that. The suffering, all the dope sickness when people are first incarcerated, trying to sort of alleviate that as best we can. And the overdose, of course, continues to be a huge component. And really, it's about engagement because at the end of the day, these are our people. These are people that we've worked with before a lot of the time, and we want to continue to be able to provide services for them. So, that's a lot of the goals of our program and connect them to as many services as we possibly can. Next slide, please. Okay, so what have been our barriers? So again, one of the things that in the early stages of the program, a lot of people were being released, and they came in on Friday, were being released on Saturday, this quick release. However, over time and in New York State, bail reform was implemented around the early part of 2020, and we didn't see as many people coming and going as quickly. So that sort of quietened down. Having said that, we are seeing people now in the last 6 weeks, and I don't have an explanation for it, but we're seeing people being released very quickly, and we are missing them. So that's a real challenge. And it's not always easy to connect with somebody in the community. Phones aren't working, just not being able to connect with people, not having good information. And if you don't have that face-to-face, it makes it more complicated. It's really challenging. COVID-19 has been massive. The jail has been on lockdown, which, again, I want to keep going and keep repeating myself when I say that face-to-face is very important. So for long periods, we were not able to see people face-to-face, which was a real problem. And that meant that we weren't able to make that connection, and they were getting released and they didn't have that connection to us. So that was extremely challenging. Again, I mentioned the unexpected release. People not picking up their scripts as well has been, something that's, for them at very high risk, and not being able to connect with them to try to sort of work them through that. And all of the other pieces that we really are happy to be able to, lost IDs for picking up their medication at, pharmacies is a challenge as well. And the one, like I mentioned, shelter transportation. And we do as much as we can to sort of work through that, and we continue to sort of brainstorm and come up with solutions. But these are the sort of barriers and challenges that we faced in this. And it's getting buy-in from the jail as well has been, challenging. I do trainings for staff in the jail. It's always very interesting to sort of see people's feedback and how they feel about this particular program. Next slide, please. So this is kind of a snapshot of the sort of, the successes of the program. So, this is a week or so old, but as of 3/7, 750 referrals we've received on the program, that's a lot of people. 334 have been engaged. It's a little higher than that now for further services, and I consider that to be an extremely high rate of engagement. Those sort of engagements vary from sort of linkage to a treatment bed, outpatient, safety planning, all of the above. So it's been an array of different sort of services provided. So our engagement rate is very, very high. Our percentage rate is very, very high. And I mentioned this before, but the value of being able to do the InReach, I can't speak to it, because you are making that connection. You are able to sort of have a conversation with somebody. You are able to talk about risk. You are able to do all of these things, and that makes the outreach so much easier and so much more straightforward. Again, everybody gets their Narcan kit, and we have in the beginning stages it wasn't following people to prison or state prison like that, but now it is, which is great. And again, just a little extra piece here. People now are going to be continued on Suboxone, buprenorphine in prison as well. So there's a lot of changes, a lot of very positive and changes happening at the moment, and it's really helpful to see that. Just a quick aside, we also have been connecting with people post-prison, because that's a very sort of important piece. Someone goes to prison, we don't always lose connection, and they will round back to us, and that speaks to the engagement piece as well. And again, success varies according to every individual, so there's no sort of absolutes in any of this. It's always the opportunity to advocate, reinforce harm reduction and stigma, and to address stigma, and to be able to sort of have people open up to you. So it's it's been a very important part as well. Next slide, please. And that's it. That's the a quick snapshot of the MOUD program at Albany County Jail.
Thank you, Ed. Well, we've now entered into our question and answer portion of today's webinar. I would like to open the floor for any questions or comments. Again, feel free to use the chat box feature to pose any questions or comments you may have. The floor is now open. Looks like we may have one question in the Q&A box. All right, it's from Rick Kagan. He says, as we contemplate treatment for the justice involved for substance use, to what extent are programs represented by the panel, including tobacco and nicotine, on the list of addictive substances? I would like to learn more about providing evidence-based tobacco dependence treatment for individuals in the justice system.
We don't include that in what we're focusing on.
We don't either.
Any other questions in the chat box? I'm looking here, give people a few minutes. All right. Seeing a couple of questions from Tina Miller. What is included in the naloxone kit and how do you get the funding for them?
So there's 2 4-milligram intranasal Narcan applicators, face shield, gloves, and instructions. Our funding is through the Office of Drug User Health at the New York Department of Health.
All right, then we have another question from Kirsten Roby. How can I get the needs assessment?
I'm actually attempting to upload that as we speak, and I'm kind of struggling here, but I will update that. I will put that on here if I possibly can. I'm going to keep trying. I'm struggling, but if I can't actually do this, which I can't, it looks like, I'm happy to send it to you, email it to you, or anything you need, because it's more than the assessment. It's like the implementation, like a harm reduction implementation guide. So I can actually send that to anybody if they're willing to put their email address.
Looks like, Ed, you have a couple of people who are interested in the assessment. Maybe we can send that out following this webinar to everyone who's interested. All right, we'll give a few more minutes on the chat box to see if anyone else has any questions. All right, looks like we have some more questions coming in here. All right, from Faith Barber, do you have OD prevention Narcan training individually or in groups?
So we do the overdose prevention individually on this program, but we also do groups as well, or we did groups as well pre-COVID for general population, not just for people in this particular program, but this particular program, it's individual overdose prevention as part of the assessment.
And we do both as well, individual and groups.
All right, another question came in. Do your peers have the ability to give clients phones once released?
We don't have the funding to provide phones, so we don't. But also in the region, in Owen and Carroll County, cell phone coverage is actually quite spotty, just given the terrain, which is another issue. I didn't get into that, the technological infrastructure, but it's that's challenging as well.
Our peers, it's a great question because it's such a challenge. Being able to contact people. We've sort of there's no consistency in how we do that. We possibly could, and it's something we continue to look into, but at this time, it's very hit and miss. It's usually when we've been working with somebody post incarceration for a little while, and then we're able to we continue to struggle, and then we end up getting them before, but there's no consistency in how we provide phones for anybody.
All right, we'll give a few more minutes and see if anyone has any other questions. We have a few minutes here. All right. A few more questions coming in here. Do you find there to be any issues with any of the inmates trying to divert the medication while they are receiving it in your program while incarcerated? If so, what are things you do in place to try to prevent that from occurring?
Yes, and I should probably have spoken a little more about that, but so diversion is something that's been a hot topic for some time. So in the initial stages of our program, we were, the jail, and again, I do want to sort of emphasize it's, they have their own medical team and they do make their own sort of decision making, but I am very sort of locked into this. So the maximum dose for Suboxone is 16 milligrams, which is now super high dose. It wasn't always that way, but diversion, and that was the decision that was made to have the actual dose at 16 milligrams. So that was the sort of approach to that. Diversions, there was a period of time, I must say, sort of the back end of 2021, where diversion numbers were very, very high. That seems to have tailed off a little bit. That's where we're at now, but diversion is an ongoing conversation.
Elin, can I actually chime in on that real quick?
Yeah, absolutely.
I just wanted to share, so I manage a handful of projects. One of them is around helping jurisdictions provide medication-assisted treatment in their jail. And we get that question a lot from folks about sort of diversion and what is it looking like and how common is it and how, what sort of safeguards can you put in place to help prevent it? And I have a list of resources that I send to folks when they ask that question. So I can send it to you, Elin, and if you want to send it out to everyone that's attending, or if we want to just send it, if somebody wants to shoot me a note, I would be happy to send that to you individually as well.
Thanks for that, Kathy. We can definitely get that out following this webinar.
Good.
All right. All right. Next question that came in. Did you get strong pushback to set up your committee sharing information due to HIPAA?
No, actually, and maybe surprisingly, I did not. Part of that might be that most of the people around the table are either covered already under HIPAA guidelines, and we all had to sign confidentiality agreements in agreement, approved by our lawyers and by the Department of Corrections lawyers. Or if they weren't covered under HIPAA, then they're covered under attorney-client privilege. So everyone around the table is kind of used to dealing with privileged information, and we certainly take it very seriously. But for whatever reason, that was not an issue.
Thank you. We have time for maybe one or two more questions in the chat, if there are any.
I'll chime in also on the sort of like HIPAA information sharing question. And again, just sort of letting folks know about some resources, and I'll share them with Elin and she can send them out to you. But on the COSSAP Resources website, there is a section on information sharing scenarios, and they're focused. There's a section focused on OFR, there's a section focused on ODMAP, and there's a section coming soon on diversion information sharing. And so I know that's not exactly the question that was asked, and it's not the exact setup that Dr. Hardcastle was talking about, but it answers a lot of questions about who can share what type of information and what you need to be making sure you're doing, and who needs to sign a consent form, and what's actually protected information and what's not protected information. So again, HIPAA is a really common question, and quite frankly, people say it a lot. when they don't necessarily want to share information or want to figure out how to share information. So just sharing that I'm sharing the information that we have some helpful tips and guidance around that, that I will, Elin, I'll send you the links to those as well.
Thanks, Kathy. Ed, I saw you had your hand raised. Is there something?
I'm so sorry. I'm still trying to put the assessment into the chat box, and I'm doing everything here. So I'm probably raising my hand and doing all sorts of crazy things, but no, I'm not raising my hand.
All right. Okay, let's see. I don't see any other questions in the chat box. I'll give one more minute, and if not, we'll go ahead and close things out. I'll give everyone 1 minute. All right, seeing that there are no questions in the chat box, we will follow up with the materials that we mentioned on this webinar. But again, this webinar is a part of a 3-part series. We encourage you to register for part 3. Part 3 will be offered on March 30th, again at 2 p.m. Eastern. Special thank you to our speakers today and IIR and our funder BJA for putting on this webinar. Thank you all and have a wonderful week. Thank you.
Thanks.
Bye.